So welcome to chapter 42, the last chapter of the module. We're going to talk about antifungals and antivirals, or specifically funguses and viruses that affect us. And we're going to start out with fungal infections. So fungi are found in soil, air, and contaminated food. Mycoses are infections or disease caused by a fungus. You might also hear fungus referred to as yeast, such as yeast infections. Those are very common even in healthy people. So there are three principal areas where fungi are encountered that require drug intervention. Systemic infection, meaning throughout the body. Dermatophytic infection, meaning skin, hair, and nails. And Candida albicans, which is skin and mucous membranes, and usually that is your yeast infection source. That is localized in the mouth, the vagina, and the GI tract, such as down the back of the throat. So, systemic fungal infections. These are your dangerous ones. Usually fungi are everywhere around us. We can't really avoid them. However, we're not necessarily living with them in our blood, in our internal spaces. So once they've made their way in there, especially with somebody who is immune compromised, a chronically ill patient, they can become very dangerous very quickly, hard to treat, takes a while to get rid of. People can end up in the hospital or on long-term medication while they're trying to get rid of this fungal infection. So systemic includes blood, bone, and lungs, and this can be dangerous, as I mentioned, in chronically ill patients. It's becoming more common in hospitals, usually seen in three major settings. Neutropenic patients following chemotherapy, messes with their blood levels, their neutrophils, their immune response. Or those in immunosuppression, say they're getting a bone marrow transplant, which is also a form of chemotherapy or treatment of cancer. They are susceptible to systemic fungal infections as well. Persons immunocompromised by HIV infections, and persons in intensive care for extended periods of time. Usually those patients who are in intensive care for an extended period of time have multiple levels of invasive things going into their body. They have tubes down their throat, they've got lines in their arm, lines in their neck, and they may be on prolonged broad-spectrum antibiotic therapy. So why do we care about that broad-spectrum antibiotic therapy? That antibiotic knocks out all the good bacteria, including the bad, which is good for infections, but it also knocks out our good bacteria, which is what keeps the balance between fungus and bacteria in our body, or on our body. So if we take out all that good bacteria, here's all the fungus allowed to run wild and be stronger and stronger, and all of a sudden we have a systemic fungal infection because there's no bacteria to balance it out, which is exactly what happens when you have, say, a vaginal yeast infection. Ecosystem is disrupted, there's not enough bacteria to balance out the fungus takes over and creates what we see as a yeast infection. So moving on to dermatophytic, which again is hair, skin, and nails. This is the most common type of skin infection, or fungal infection. It's more annoying than serious, and symptoms include itching, discolored, and scaling skin, inflammation, blisters, and broken skin. And you might also hear it referred to as its proper name, which is tinea, T-I-N-E-A. And that, depending on where it is affecting the person, is going to say tinea corpus, which could be the body, tinea inguinum, which I think is the groin. I'm sorry, unguium is the fingernail infection, which is also referred to as onychomycosis. So again, hair, skin, and nails. These infections are difficult to treat because the drugs can't really penetrate that thick layer, that non-living cornified layer of the epidermis. So, moving on to Candida albicans, which is our yeast infections. Again, mouth, pharynx, esophagus, GI tract, bladder, vaginal thrush is the one that occurs in the mouth. And these, again, are usually more annoying than anything else. They can be sort of disruptive to the patient, especially if it's in their mouth. It can cause eating to be a difficult process. And it can be irritating, itchy, painful, etc. So, moving on to antifungal drugs. They have no antibacterial or antiviral activity. They affect certain pathogenic fungi only. And they are always fungicidal, meaning they kill it. If you give the fungus a chance to live, it will not die naturally. It will just keep on coming back. So what do these drugs do? They change cell wall permeability. or affect cell wall synthesis. No cell wall, no cell, dead fungus. That's the basic gist of that. So, drugs useful in the treatment. The result is the same. I'm trying to read through the long notes so I can get through that last part there, which really, so flucytosine, which is 5-fluorocytosine, is thought to have two actions within the cell body and nucleus, but not on the cell wall. So that's a little bit of a special mechanism of action of 5-FU. It's considered an anti-metabolite, meaning it prevents metabolism. If the cell can't metabolize or go through the metabolic process, it will die. So systemic antifungal drugs. We're back to our systemic infections. These are our big guns, the ones we save till the last sort of treatment option once we've identified that somebody has a systemic fungal infection. Amphotericin B. It's a broad-spectrum fungicide used for the treatment of aspergillus, or the disease would be aspergillosis. And it's first line for systemic fungal infections. However, it comes along with a lot of side effects and I think a ton of drug interactions. Action, drugs used. Side effects include fever, chills, muscle spasm, headache, vomiting, and hypotension. The effects may be reduced by a pretreatment with an NSAID, such as ibuprofen or naproxen, hydrocortisone, or diphenhydramine, reducing the dose and infusion time, or using alternate day administration. So all of those can help cut down on the side effects. There is an increased potential for hypokalemia, which is low potassium, and cardio and renal toxicity with co-administration of amphotericin B and chemo drugs, anti-neoplastics, as well as steroids and digoxin. So combination therapy with azole antifungal drugs may induce fungal resistance to amphotericin B, so we never give azole antifungals with amphotericin B. So moving on to more antifungal drugs. The echinocandins include anadulafungin, caspofungin, and micafungin. That third one there, starting with the M, is the most common one used out of this class. And again, fungicidal activity against Candida species, fungistatic against aspergillus. So you take a risk. We're only stopping it in its tracks. We're not killing it. Fungi are pretty little resilient things, and they will come back if you are not sure that this is going to take care of the problem. So these drugs are usually used for esophageal candidiasis and candidemia, meaning infection in the blood. Adverse events have occurred. The safety profile is far better than any other class of antifungal drugs. It includes fever, headache, diarrhea, rash, and phlebitis, which is an injection site reaction, as well as elevation of liver enzymes. And we talked about flucytosine a little already. It's a nucleic acid analog and an anti-metabolite, not used alone or as a first-line therapy because of frequent resistance. However, it can be used in combination to sort of boost the action of the two drugs together. Adverse effects include bone marrow suppression, jaundice, abdominal bloating, GI hemorrhage, nausea, vomiting, and ulcerative colitis. All of those things sound super awesome. This drug isn't used too often. Just to let you know, usually I've only seen it used in chemotherapy situations. So, azoles, A-Z-O-L-E-S, ketoconazole, fluconazole, itraconazole. As you can see, a theme there. Azole is the end of the name. They're used for a wide spectrum of activity against common fungal pathogens, to include fever, rash, nausea, vomiting, diarrhea, headache, and hallucinations as the adverse effects that come along with them. You might see these used for topical fungal infections. Some of them might be used for, we'll get back to that. Hold on one second. I just want to go on to the next page and see if they move into it. Yep. So individually, we'll move into it. Fluconazole, used for cryptococcal and coccidioidal meningitis. That's a big name. That's usually inpatient treatment. Fluconazole is used outpatient for simple things like yeast infections. However, those ones you see there, cryptococcal and coccidioidal meningitis, most likely going to start out as an inpatient treatment. Itraconazole is used to treat several types of fungal infections to include histoplasmosis, paracoccidioidomycosis, and blastomycosis, as well as invasive aspergillosis and fungal meningitis. Absorption is increased with food, just a little side note there. It's the broadest spectrum azole, and is highly effective against yeast and opportunistic infections. These are things that people who are healthy might not come into contact with, but somebody who's immune compromised, again, our chemotherapy treated patients, our transplant patients, and such as kidney, liver, etc. transplant, and our HIV patients. So the reason these don't sound familiar to you is because you don't come into contact with them every single day. Moving on, nystatin. Little or no absorption with oral administration, so this makes it good for intestinal and oral candidiasis, so thrush. No harm to fetus for pregnant women, so also okay for them to take. And again, can also be used for vaginal candidiasis, usually as a cream. Oral nystatin has been associated with diarrhea, nausea, and vomiting. You also see nystatin used for baby butt rash. So that rash that babies get is a fungal infection, that diaper rash. Nystatin cream can be used topically on that. Cryptofulvin is effective against fungal infections of keratinized tissue, the hair, skin, and nails. It binds to keratin and prevents the fungi from utilizing the protein. So if it can't use the fungi, then it's going to eventually die because it has no nutrient access. So food increases absorption. The higher fat content, the better. That's just a little random one there. And again, this is going to be sort of a long-term, like weeks of a medication, not just a couple days, because it does take a long time to get rid of. Terbinafine, more commonly used for fungal nail infections, as well as athlete's foot, jock itch, and ringworm. It is fungicidal, and it's well absorbed after oral administration. Adverse effects include diarrhea, dyspepsia, pruritus, taste disturbances, and urticaria, which are hives. Again, months of treatment here. Contraindications for antifungal drugs. These drugs should not be given to any patients with sensitivity. That's an obvious one. Itraconazole and flucytosine should not be used in pregnant women as they have caused fetal damage. You can see a long list of antifungal drugs on slide 18. And in the next video, we will move on to antiviral drugs.